Good afternoon, everyone. Today's combined clinical rounds is on the topic of PIPAC, which is pressurized intraperitoneal aerosolized chemotherapy, which is a new ray of hope for patients with advanced peritoneal surface malignancy. We intend to start with the case history, followed by the radiology review and the pathology review, followed by the technical description of PIPAC, the anesthesia perspective, the procedure per se, and review of literature, followed by the summary. Coming directly to the case history, case history is about a 55-year-old gentleman, a resident of Agra, who was employed in a private job. He presented with no comorbidities or past history of surgical interventions. There was no history of malignancies, no addictions, or any past history of substance abuse. His chief complaint was pain abdomen, which was limited to the right lower abdomen since August 2020. Insidious in onset, non-progressive, and continuous in nature, though dull aching, which was relieved by simple non-opioid medications, with no other significant complaints associated with pain. There was history of occasional vomiting, which contains ingested food particles. He does give a history of loss of approximately 10 kilos of weight in approximately 3 months. He was initially evaluated in August in 2020 at a private hospital in Lucknow, wherein a few investigations were done. The first was serum CEA, which was 6.9. A CT was done, which showed moderate ascites, or mental caking, and along with it, there was fat stranding and mesenteric thickening of the terminal ileum, ICJ, and cecum. There were local regional lymph nodes with necrosis. Uh, the biopsy was taken at a private center, wherein CT-guided biopsy showed metastatic carcinoma. He was diagnosed as a case of carcinoma colon with peritoneal carcinomatosis and was managed with systemic chemotherapy initially. He was given one cycle of paclitaxel and oxaliplatin in the month of February 2021, followed by 7 cycles of oxaliplatin and capecitabine 3 weekly till September. This was followed by the patient referring himself to IRCH. When he presented to us, he had a performance scale of 1. There was no significant findings in the form of pallor, icterus, lymphadenopathy, or pedal edema. He had a BMI of 22.6. On per abdominal examination, there was distension, and hard palpable nodular masses could be felt in the epigastrium, hypochondrium, and the lumbar region. The digital rectal examination was normal. The other systemic examination had no significant findings. I request Dr. Shaina to take over for the radiological findings in this.
These are representative images of the single time point scan of the patient. Baseline imaging was not available. The axial CCT images of the abdomen show soft tissue in the right subdiaphragmatic location and along the surface of the liver. Multiple soft tissue deposits are also seen in the transverse mesocolon and in the left paracolic gutter. There is equivocal thickening of the ascending colon, and plaque-like thickening, plaque-like soft tissue is seen in the mesentery, which is contiguous with the serosa of the bowel loop.
I request Dr. Sriram to have a pathological.
We received a block from outside labeled as CT-guided omental mass biopsy. So this was a lower power image. We had this many fragments, but predominantly everything had a fibrocollagenous tissue, and only this fragment had some amount of muscle. The lowest part is the 4x power, where we can see skeletal muscles arranged here, and suddenly we are seeing some different transition from the normal skeletal muscle. And on higher power images, we can see that this is a normal skeletal muscle, and here we are seeing there is an infiltrate of tumor into the skeletal muscle. Higher power image, we can further see the cells are arranged in cords and strands, along with occasional sheet-like pattern. The cells had minimal amount of atypia, along with some amount of pleomorphism. We thought it as a metastatic carcinoma, then we adenocarcinoma. Then we went with a workup of CK7 and 20, and CK7 was passive positive, showed expressed passive positivity, and CK20 was diffusely positive, consistent with the GI primary.
With this diagnosis of carcinoma of cecum with peritoneal carcinomatosis, 8 cycle of chemotherapy, I request Dr. Ashutosh to take.
After case history, radiological evaluation, and pathological assessment, we reached to the diagnosis of carcinoma cecum with peritoneal carcinomatosis. The patient was post 8 cycle of chemotherapy. So we bring the case into the MDT and discuss all the issues pertaining to the treatment. So initially, first point was how should we go, whether curative or palliative. So as the disease was limited only into the cecum, but there was a lot of disease in the peritoneum, in the mesocolon. So initially, after discussion, it was clear that we are going with the palliative intent. So in palliative intent, how we need to proceed. So secondly, we can go ahead with the cytoreductive surgeries followed by HIPAC. But it was a major surgery and patient not willing for this major surgery. In fact, the GCO was good. Disease was limited only to the cecum, and there was a significant peritoneal carcinomatosis, including the leeward surface and the mesocolon. So finally, we tried for some near approach, and that was PIPAC. So final plan was diagnostic laparoscopy followed by the PIPAC, pressurized intraperitoneal aerosol based chemotherapy. And the teams were involved with surgical oncology, oncoanesthesia, and PIPAC team. So basically, to begin with the PIPAC, we should know this is the treatment for the palliative intent. And basically, this is the mode of drug delivery inside the peritoneal cavity, just like PIPAC. But in this particular treatment, we begin with the aerosol burst chemotherapy. And it's a minimal invasive procedure. We can do it in a daycare also. And in this particular sort of treatment, we are able to produce a homogeneous distribution of chemotherapeutic drug inside the peritoneal cavity, and there is a better absorption of drug into the tumor mass. And simultaneously, we can also alleviate the symptoms like ascites and also induce regression in peritoneal metastasis that significantly improve quality of life. This is overall and general assembly that we can see here. This is entire machinery part. Here we can see the PIPAC unit. In this, there is the head injector, which injects the pressurized chemotherapy. This is the syringe with the chemotherapy solution or cytostatic solution. And this is the main pipeline, which can sustain the pressure of this injector head. And this goes to cannula inside the peritoneal cavity. These are the special cannulas, optical with the balloon that limits the loss of air from the peritoneal cavity. From here, there is the insufflation of CO2 laparoscopic unit. After that, there is another cannula. We usually keep opposite to this cannula so that we can visualize where we are injecting the drug. So from here, this is the laparoscopic port camera, and it's attached with the CAWS. CAWS is the closed aerosol wastage system. It's very special, and it has two filters so that the occupational hazards can be minimized. And these are the particular things that we need to keep in the mind while doing the PIPAC procedure so that we can maintain the safety for people per se and the patients as well. And the first and foremost is the patient's tight pneumoperitoneum. This we can check by measuring the zero flow of insufflator unit while we are doing this PIPAC. Second is the direct airflow. Direct airflow, the air comes through the HEPA filters. These are the filters which has the capacity to arrest all the micromolecules, microparticles less than 0.3 micrometer in the size. And third is the lamellar flow, so that the air directly goes into the exit vents, and minimal sprays of aerosol based components to the outside. And third and very important part is the remote application of injector system. So we keep this injector system outside the OT, and from where we control the entire system. So these are the OT modifications. First important is remote anesthesia monitoring. My anesthesia colleague will focus on this in detail. Second is HEPA filter, as I have discussed, and third is lamellar flow. For patients per se, there is no need of bowel preparation. Patient should be for NPO for 6 hours. Thromboprophylaxis, we generally prefer deltiparin 5000 international units subcutaneously. Antibiotic prophylaxis, single dose of cephalosporin sulbactam. The same PIPAC procedure was done at 29th of December 2021. So what are the different requirements for PIPAC procedures? So first is the pressure drug injector system. That is the pressure drug injector system. Here you can see This is the injector system, and in this, this is the site for the chemostatic drug. And from here we can target the pressure. We can usually target the pressure between 200 to 290 psi, and with that pressure we inject chemotherapeutic drug inside uh, peritoneal cavity. Second is smoke evacuator system, or CAWS, closed aerosol wastage system. This part of particular tube is connected to the laparoscopic head of a trocar, from where after the completion of procedure we usually remove entire aerosol through this evacuator system. This has two serially placed microparticulate filters that are placed on the exit side, and they ensure the safety of OT and environment. This is very important, capnopen device. This is the unit that is placed inside the peritoneal cavity. This is the head of capnopen, and it has a small hole from where the entire drug is injected in the form of aerosol. And it also contains a micromotor's nebulizer, so that generates liquid chemotherapy drug into the aerosol. And this is a single use, and we have placed this rubber on this particular length after measuring uh, this, the head of this capnopen should not touch any internal visceral organ. And this is the trocar. These are specially designed optical trocars, and with having the balloon, so that the air is confined to the peritoneum and there is a minimum or no leak from the peritoneal cavity. And third important part is chemotherapy drugs. There are mainly oxaliplatin, cisplatin, doxorubicin, and mitomycins we are using. So the dose is generally 10% of the systemic dose, and cisplatin we are using 7.5 milligram per meter square, and the doxorubicin is 1.5 millimeter per square. And an important part is the safety checklist. So the standard TIMEIT procedure should be followed: patient name, chemotherapeutic drugs, team members, whether they are full of safety measures or not, protective sheets inside the OR. Then come to the patients and whether the trocars are tightly placed or not. There is a sealed pneumoperitoneum. We can check by insufflator zero flow rate, CAWS is working or not, inflation port is open or not. So insufflation port is open or not, we should check all these things. So once we entered the abdominal cavity, we must check the ascites status and the PCI, the burden of the disease inside peritoneal cavity. So these are the basic safety checklists that is important to perform.
Good afternoon, everyone. I will be covering the anesthesia concerns related to the PIPAC surgery. Considering the uniqueness of this surgery, there are very specific anesthetic concerns related to the surgery. First and foremost, our aim is to patient safety. And before the surgery, we have to have a clear communication with the surgical team. Plus, we should involve the nursing staff as well as any other OT technician or any other OT staff involved in the OT. As discussed previously, we are generating chemotherapeutic drug. Aerosols are generated for the surgery. So if there is any leakage of these aerosols, it can be of occupational hazard for the health workers. For this, we have to prepare the OT space as well as prepare the staff to ensure the safety of the patient as well as to reduce the exposure of the OT staff with the chemotherapeutic drugs. So as discussed previously, the OT space is to be prepared in beforehand. For this, in our setup, we had one operating room as well as an adjacent induction room. Once the patient was taken inside, anesthesia was induced, and insufflation and insufflation not. First, the ports were inserted and the patient was prepared. Just before generation of the aerosols, whole of the OT room was evacuated. The OT staff, that is the surgical team and the anesthetic team, was taken into the induction room, and the OT room was completely sealed. The OT room must have a closed aerosol waste system as described previously to prevent the OT pollution. In our setup, we also discussed with the AC units to increase the number of air flows per hour to decrease the number of aerosol. If any aerosol was produced, it was to be evacuated. As the whole of the OT staff during the procedure was outside in the induction room,
We had a provision of remotely monitoring the patient. Here we see in the left side, we see this is the OT room. We are looking from the door between the OT room as well as the induction room. Once the doors were closed, this was a small window through which we were monitoring the patient as well as the monitors could be. For the anesthesia plan, we had planned the procedure in general anesthesia with total intravenous anesthesia technique. For the monitoring, ASA guided monitoring, standard monitoring was used. ECG monitoring, pulse oximetry, capnography, and BP measurement. If required, invasive BP monitoring and BIS monitoring can be done. For the IV lines, we had secured 2 IV lines. One was completely dedicated for the propofol infusion for the total intravenous anesthesia, and another line was attached to the extension line, and it was taken into the induction room, through which we could give emergency drugs and fluid boluses. We had one-way valve tubings to reduce the backflow of the drugs, and kinking was we made sure that there was no kinking of the infusion lines when the doors were closed between the OT room and the induction room. And one anesthetist and the surgeon, completely equipped with PPE, that is the personal protective equipments, were kept in the as standby in the induction room. It is very important, as some of the case reports have, previously it has been reported that a patient can develop anaphylaxis to the chemotherapeutic drugs. If such a situation arises, the one selected anesthetist and surgeon with the proper PPE kit will only enter the OT room after the completion of the complete evacuation of the chemotherapeutic drugs. Then only the other staff can be allowed to enter the OT room, and simultaneously the resuscitation can be initiated. This is the photograph of the induction room. Here we see this is the OT complex, and this is the induction room. This is the IV stand through which the IV fluids is connected to a second IV line, and this is the extension line. And this monitor is very important. This is actually a mirror monitor that was depicting the same monitor as the monitor that was attached to the OT to the patient inside the OT complex. As discussed previously, for the induction, we used IV propofol by Teva pumps. For IV induction and analgesia, we used fentanyl 1 mics per kg. Other alternatives are morphine and remifentanil. For the paralysis, we used IV atracurium. In some patients may have gross ascites, for which RSI may be required. In those cases, we can use suxamethonium followed by atracurium. For the analgesics, IV paracetamol 1 gram was used, and diclofenac 75 milligram IV. Other alternatives are LA infiltration, local anesthetic infiltration of the port sites, and abdominal blocks can also be used. Once the procedure was completed, the aerosols were evacuated, port sites are closed. We reversed the patient and patient was extubated. The patient was stable, so the patient was shifted to the post-operative anesthesia care unit and later to the ward in isolation. Rarely these patients may require ICU care also. For the post-operative analgesia, we used paracetamol, NSAIDs in SOS basis in the post-operative care. Now I'd like to ask MD Russell.
Good afternoon, everybody. True sense for oncology, it is not a surgery. You know, it is a novel drug delivery system, and where the surgeon is mandatory. This is actually that new first time we did here. After, because of the COVID, we couldn't do this. But this is a port placement. You know, this thing is actually exactly the port to be placed as per the literature in the left subcostal area and the left iliac fossa. But in such a disease was such a kind of disease was there, we had to put this port in the right subcostal area. So that is the same thing is there, and we see 2 ports are usually required, but so many people putting the single port. Nowadays it is improvised. And so when you see this thing with the laparoscopy, you see the same findings which we have seen in the CT scan: omental thickening, multiple peritoneal mesenteric deposits, plaque-like thickening different parts of the peritoneum, and minimal ascites was there. And peritoneal index was 15. And one important thing to note, that peritoneal index 15 means that is so high after 8 cycles of chemotherapy. So that is not an ideal case for the surgery as per the colorectal cancer and peritoneal mets is concerned. So this is a kind of a small video report. This is the jet what Ashutosh shows. This is the captain open, and we people, when we stand outside, we are enjoying only this jet only. And because this is nice looking, and it, because of the pneumoperitoneum, it covers the whole abdomen with uniformly. And this is the jets only. For half an hour we have to see this from the outside. And this is this thing, and silent, totally the total silence is there. PIPAC, one important thing, PIPAC working hard silently. One important lesson the PIPAC is teaching us, because hard work, you work hard in silence, but let the silence, that results break the silence. Ultimately, what is the result will come. So this is this thing, small video, and Maddie put this, and this is the same thing, and we are observing from outside and for half an hour. And post-op procedure, if you see this procedure was uneventful. First time we did this thing under the guidance of Professor Dev, he was constantly there. And actually, but post same day we extubated the patient, but POD2 were very uneventful, and patient, we see the bile discharge was there in the port side, and because we know this commonest complication is the perforation. And anyway, the patient was vitally stable. We explored this thing and closure this perforation as usual way, and patient was recovered very slowly, and we discharged the patient on 8th post-op day with the following further evaluation process. So if you see the review of literature, there are not so much paper, peritoneal surface malignancy coming up gradually over the decades in India also. It is so many centers performing this thing. And pseudomyxoma peritoneum malignant peritoneal mesothelioma, that is the standard for the CRS and HIPAC. And but other also evaluating like ovarian cancer, few randomized control trials are there, gastric cancer, CRC, colorectal cancer with peritoneal mets. There are so many challenges are there from the diagnosis, management, even in the response assessment, every aspect. Even well, that to be considered as a terminal kind of disease. So people are not so much interested in that, and patient perspective also their quality of life, day-to-day progress of the disease. So this is a landmark trial. If you see, this is a big trial, and they have included 14 randomized control trial, and that published in Lancet Oncology, and 10,553 patients. If you see this from they have calculated the median overall survival when the peritoneal mets is there, when the survival drops down, including the single mates, there is survival is here in the 20 months, but along with the mates, the survival drops down. So in this paper, they have shown when the colorectal cancer, the peritoneal mates, the prognosis is so bad. So that is overall, if you see this, what is the present picture after CRS, colorectal cancer with the peritoneal mates. If you see this with the CRS and HIPAC, the median DFS is 12 to 15 months, overall survival 23 to 53 months. And 15% patient also get cured. That is very important. But PCI is the most important factors for the surgery. But when the PCI is 15 to 20, that is relative contraindicated. In this patient, particularly after chemotherapy, when the PCI is 15, that is not a candidate for the surgery. So there is a role of systemic either chemotherapy or PIPAC. So that is a PIPAC is always better in the sense of in quality of life. So there is why the PSM patient have the poor prognosis. We all know this thing, because that is only the 2% cardiac output directed to the peritoneum. There is even so even this thing from this paper also we have seen when the peritoneal mates are there, there is 30% shorter survival in compared to the only the visceral met or single visceral met. Even in the other therapy also the same results are there. So there are the evaluation. If you see this thing, the chemotherapy, there is a novel concept that started in 1970. The catheter-based IP, HIPAC, EPIC. We are also doing the EPIC and NIPS also, and NIPS the neoadjuvant interperitoneal chemotherapy with systemic therapy, and PIPAC recently. The PIPAC concept not so old, because 2000 only they described in 2000, and the first that is performed in the human body in 2011. So this is the thing. If you know this is why it is the interperitoneal chemotherapy, the rationale you all know, because the much more concentration is there, because of the plasma peritoneal barrier, the systemic chemotherapy is not so much effective. So that's why that interperitoneal chemotherapy is much more important, that it is coming up gradually very large way. So these are limitation everywhere is there, that poor drug distribution because of the different factors are there, limited penetration of the drug, even the systemic circulation, escape of systemic circulation, local toxicity also there, and logistic times, cost, so many issues are there. So this is also the Ashutosh also mentioned about this thing, that is normally PIPAC pressurized interperitoneal aerosol chemotherapy, that is for the mainly in the palliative intent, and this is minimum invasive procedure, that is not a big surgery and minimally invasive procedure, and that is mainly intent for the alleviate the symptoms only. So this is the indication at present. If you see the literature, there are only the carcinoma, stomach, mesothelioma, colorectal cancer, ovarian cancer. These are coming in the great way, and there are so many contraindications also there. We cannot do this thing when the performance strategy is poor. life expectancy less than 3 months, or there is decompensated ascites or bowel obstruction, that we should not go for this. So these are the advantage and disadvantage. You all know this intraperitoneal chemotherapy, that is like increase intra-abdominal concentration, low systemic toxicity is there, homogeneous distribution, the good quality of life, and there are so many disadvantages also there. We discuss about that. So these are the things. This is the results I am talking about. That after 3 cycles of PIPAC, we see the regression. What are the regression score, both the clinic and histopathologically? That is also published. That is good results are there. If you see this from this chart only, there is the histological regression score 36 to 91%. So that is a good response is there with the PIPAC. The same thing reflected in this that forest plot chart here. We can see this regression rate around 64.23%. So this is the overall survival. If you see this thing, the PIPAC along with the upfront chemotherapy, always this median overall survival is around 9 to 18 months like this. So even after second, third line chemo, if we compare, the PIPAC has got the better overall survival, that is around 8 months. So even that is not important thing. Is the important thing is the quality of life of this patient is improved with the PIPAC. So this is also, so many studies are there in the quality of life evidence in a different study. Also they shown this thing and good quality of life. So these are the new recent advances are there. PIPAC is coming, allostatic PIPAC, hyperthermic PIPAC, and aerosolization of the nanotherapeutic also. Even the PIPAC has a new adjuvant settings. You know, there are so many studies are there. They show around 5 to 14% also they're having the good response that patient can undergo CRS and HIPAC. So these are the new things are coming up. So I request Dr. Deo, our HOD, to summarize this session. Thank you.
Right. Just to summarize, basically this highlights a new drug delivery system. We have the options in peritoneal surface malignancies, especially when we see the advanced patients. The conventional options are only systemic chemotherapy, we have been doing this for the last 3 decades. Of course, not with very encouraging outcomes. Recently, HIPAC and intraperitoneal chemotherapy has been tried for the last 10 years, where you put liquid form chemotherapy within the abdomen during surgery. So that also has shown modest outcomes. So this is the new development. Basically, it is aerosolized chemotherapy for a better distribution at a lower dose. And what we are taking advantage in this technique is a therapeutic capnoperitoneum. That means you are increasing the intra-abdominal pressure and driving the chemotherapy aerosols into the tumor under pressure. So the penetration is better, toxicity is less. So it is a simple daycare procedure. So that is very appealing for PIPAC. So this has been started as a palliative sort of intervention, mostly like any other interventions for advanced malignancies. But if you see the outcomes, response rates, pathological response rates, we are able to monitor the response, because peritoneal surface malignancies monitoring on imaging is very, very difficult. CT scans, MRIs, PET scans are not accurate. The beauty of the PIPAC is we can monitor the response directly under laparoscopy and document the pathological response, which I think most of the centers are showing almost 60 to 90%, 60 to 80% pathological regression. And this is repeatable. Most of the centers who are doing high volume these procedures, these patients need 1 or 2 days of admission, not many side effects of systemic chemotherapy, and very good response. So that is the reason we thought we'll start this program at AIIMS. The only main problem with this is it is an elaborate setup. Fortunately, we have excellent team with us, the anesthesia team, the medical oncology team. So those facilities are there. The main barrier is the capnopan. So this company has a patent for the capnopan. It's costing 2 lakh rupees right now. So I talked to them. We have taken few capnopens on free basis, but in the long term, we are asking them to cut down the cost. And there are certain groups which are also trying to innovate. It is not a rocket science. It is just a nebulizer. So there are a lot of other groups are also trying to innovate low-cost capnopens. So once they come, I think it will become more, we can use for more patients. So this is the overall summary of the PIPAC. So this I've already highlighted. So the challenge is peritoneal surface malignancy, current options, we have very limited options. Not all patients are suitable for HIPAC. So do we have a good option? PIPAC seems to be a novel treatment approach with an innovative drug delivery system. It seems to fulfill most of the objectives of ideal approach. In advanced cancer patient, what we need is a simple treatment with a very good outcomes, with a good quality of life. So even if you are giving 8 months to 10 months survival, he is not suffering with severe toxicities, multiple hospital visits. So that is also one of the main aims of treatment in stage 4 cancers. So the initial global experience is promising. It's actually started in Europe, in Germany and Switzerland. So there are 2-3 groups who are actually propagating this treatment in a big way, but now it is catching up. A lot of centers in Europe which are doing PIPAC, and North America it has just recently been approved. In India, it started in few private centers. For AIIMS, I think in the government center, this is the first case we did. For this, we need to do a course in PIPAC. The surgeon has to do, a qualified surgeon has to do a course. You have to have a certified training. Then only you are supposed to do this PIPAC. So I did a course 2-3 years back. Dr. Ray did a course. And we need to have a safety checklist in place. And most of the things, they actually off-label use. There's nothing new in it. Laparoscopy, capnoperitoneum is already there. Chemotherapy utilization is already known. It is just off-label use of the same approved drug in a different modality. So ethical issues are involved, so that for any large trials you need to take ethical clearance. So we have prepared a project for a pilot study for advanced peritoneal malignancies. We will be starting the program soon. So the basic idea of sharing this experience is to see the feasibility of doing it in a government center, except the barrier of the cost of the capnopen. Rest all can be done in a setup like AIIMS. Thank you. So you can have any comments or any questions. Yes, Tony. No, we cannot compare HIPAC with PIPAC. HIPAC is actually done with a curative intent in a moderate volume disease where you are surgically extirpating the entire disease, then giving chemotherapy. We have 2 decades of evidence for HIPAC with a good survival outcomes, of course, in a selected patients. PIPAC has emerged as an alternative where HIPAC is not suitable as a palliative modality. HIPAC, the PCI is very high. That's what Dr. Ray has highlighted. PCI more than 18-20 for a colorectal cancers. HIPAC and CRS and HIPAC are not effective. So these are the patients who are taken initially for PIPAC. Now there are encouraging reports after PIPAC you can downstage, and if they become suitable, you can take them for HIPAC.
So just on lighter side, I think you need a separate OT for this.
No, sir.
Because
Actually,
if you want to run the program routinely,
yes.
you have to have the setup ready.
Yeah.
You have to evacuate each time.
Absolutely. Remote anesthesia is already there. Dr. Sushma has actually, I think, planned, because we were doing remote anesthesia, if Dr. DN remembers, for intraoperative radiotherapy. So it is a similar sort of setup where all the healthcare workers should come out of the operation theater when radiotherapy or chemotherapy is being delivered. So that setup is already there.
The intraperitoneal chemotherapy, when it came for the ovarian cancer decades ago, one of the pharmacological basis was that once your disease less than 0.5 centimeter, then the drug gets diffused nicely in the peritoneal surface deposits. Then it works better.
Yes.
That's what people did so. So suppose in such a case, like suppose if you do the debulking initially, try to remove as much as possible, and later on next sitting you go for this PIPAC kind of thing.
Yeah.
Maybe make it a little better.
Absolutely. So that's a very valid question that's still evolving. The question of debulking followed by HIPAC or PIPAC is already being explored, because you minimize the disease volume. In HIPAC, the penetration is 3 to 3 millimeters tumor depth. But what they have shown in PIPAC, there are 2 things which are happening. One is acute peritonitis because of chemical peritonitis of chemotherapy. Second is cell kill up to 3 millimeters. Then what it does is there is a peripheral vascular zone in a large tumor nodules in the pushing borders. It gets sclerosed after PIPAC. Then what happens, because the blood supply is cut off, the big nodules also are regressing after PIPAC. So that is why we are not doing debulking, because it is a messy procedure in these patients. You cut them and there's a lot of morbidity. Then you add PIPAC, the complications may increase. Yeah, the intra-abdominal pressure, it's around 12 millimeters of mercury, that's what. And the injection pressure is around 200 psi. So that we have to be careful. If it exceeds, yes, there is a theoretical risk of embolization. Anything you have to add, Dr. Ray?
And in our cases, in our case also our experience is very less because as per the DVD is concerned. But as per the rule, as per the guideline and protocol, we have to have the use. We are using this thing also the thromboprophylaxis 12 hours before the surgery and 6 hours after surgery. So in HIPAC we continue for the till the patient discharges, but in PIPAC normally we'll start at the single dose and another one dose after 6 hours. That's another.
That is thromboembolism.
that is different issue altogether, sir.
Dr. Sushma, any comments from your side, please? Because anesthesia also plays an important role, especially for remote monitoring. So these.
There is any new surgeries going planned by surgical department, we always try that as best as possible, and we planned it. Although the Dr. Dev is saying that remote monitoring wala OT, although this OT was not there with us, but this OT we created remote monitoring. We are monitoring outside within no time, within 1 day, technicians, and it was a good experience. Anything new, it's a good experience.
Yeah. So basically, it is going to add another dimension, another option to these patients whom normally we
high-tech palliative medicine, not surgical.
Palliative. So
it's a high-tech palliative medicine, not a surgical.
It's a true multidisciplinary approach. Everybody is involved, including medical oncology, anesthesia, and surgical, and everybody.
So I think if we can provide good quality of life without any medication, and if we can see that his histopathologic response is also good, so definitely symptoms will be less and patient will. So anyway, he is going to end his life, but he will end with dignity.
Yes, no, sir. The current protocol, what is recommended is the PIPAC after 6 weeks, we need to repeat a laparoscopy for response assessment. Then PIPAC, normally they are recommending 3 to 4 sittings. So that is another challenge. The cost is going to be added. So that is why we are not pushing this modality in a big way in a government setup. Unless the cost goes down, the capnopen cost goes down. So 3 to 4 sittings of PIPAC, then you can assess your response like 3 cycles of chemotherapy. And some centers are also adding systemic chemotherapy along with PIPAC, a combined approach. So it is just to share our own experience. This is only one case. This is a long way to go, but we are planning to start the PIPAC program. So if there, yes. It has already been cannibalized. The capnopen Indians, as usual, they break it open. They saw the technology. There are 2 people. I think Sanket Mehta is Bombay, so they are trying. I'm sure it can be done with the help of IIT. Yeah, absolutely. It is not a big technology because it was invented by them. They have patented it for 10 years. So that is the only issue. But the cost should not be a problem if you develop a low cost innovation. So if there are no more questions, we'll close the session now. Thank you very much. Yes, Dr. Please. Okay. Sure. Thank you. Thank you, Dr.